really, we appreciate this. And then I'll try and speak to fourth industrial revolution with regards to the infrastructure that is important for really making it work. And hence, I'm showing this infrastructure in front of us. And then, of course, AI in terms of some of the applications and more so in Theranostics for us specifically. And thanks for really giving us that confidence when we won that award. It has given us the leverage, of course, to do even more of for IR and AI. And then just to remind colleagues that nuclear medicine in itself, indeed, and especially infrastructure, is a national infrastructure. All universities are involved and should be involved and are welcome, including, of course, people that are really from the private sector. Just to, again, recap that the infrastructure in itself is an anchor center for IAEA to try and really address the sketch that we normally see in the continent, wherein there is really hardly any skilled or trained personnel that are really competent who can take up the sketch of cancer, of dementia, and then of cardiovascular diseases. So this infrastructure of ours is doing that. And then, of course, that's one of the benefits of this. And then having said that, of course, we just not long, we appealed to the specialist training body to actually that we should have a African reach wherein we can collaborate, co-create, and then have the community-based. And of course, AI in itself, without the community, it won't contribute well. AI has to be demonstrated in terms of caring, but we must commit to making sure that people are really skilled. And then in this, of course, we have to, when we speak, for instance, our infrastructure and everyone else, after having said so, we collaborate internationally with a lot of colleagues, but it's important that we must start to think about the African reach first and enhance and start to recognize each other's skills. And that way, the importance of AI and data will be realized. Harmonization of data collection is what is going to be important. But how do we do that if we don't have regulations, if we don't have the manner of how we recognize each other, and we always, of course, there's nothing wrong. We must work with the high-income countries if we ourselves cannot help each other. If your neighbor is doing well, you are likely to do well than if your neighbor is suffering. But if your neighbor collects data in a different way from yourself or analyze data in a different way, then it's not going to be helping as well. Rich data is going to be the way that is going to make us to decentralize training, to be collaborative, and then to really address what is affecting us. So how can we do that? And then I'll show the examples after that. We, as NuMeRI, we have a vision that we are leading in Theranostics and innovation for a better health. We do that because we do have the clinical part, the radiopharmacy and radiobiology and medical physics, as well as the preclinical facility. And then all of those, we can therefore make some new radiopharmaceuticals, but the old way of doing new radiopharmaceuticals will be taking long, and then I'll show how AI can help. Of course, we have means of looking at a human being and then cascading to say, what is the disease profile? How can we diagnose it better? How can we look into the blood? How can we look into the biopsies to make new biomarkers? And therefore, if you have got new biomarkers, you can have a new drug development. And then, of course, I will come back to the AI about this. And then, of course, we do look at the epigenetics of what affects us here. And as I've spoken about rich data, if we get data from across the country and in a continent, it would enable us to actually then do genetic sequencing that is relevant, and therefore we can have also a bioinformatics that is going to be helping us to really again take the bench to bedside that is relevant and helpful to our disease sketch. And then we can do that, of course, by making sure that we start by looking at the micro part of it, microspect and micropect. And then as we do look into this, then we can know the distribution and alter what we thought we wanted to do, and then have a critical knowledge contribution. So impact is really having critical knowledge contribution, but that again can be enhanced by, for instance, utilizing AI to see what model of a rodent do you need, and then what type of cells do we need, because if you choose the wrong ones, then you'll obviously not come with the right diagnosis and implementation to human beings. But in all that we do, we have to make sure that there is safety to all of ourselves and the environment around us. And then we also have to ensure that what we inject is really of the lowest we can get, and then getting the maximum input. So we've got to then utilize AI technologies to say, how much can I give that is little, that can give me the information that tells me that this drug that I'm injecting is going to last this much, it's going to go to various organs and in a certain predictable manner. And therefore, you can be able to know whether when you are treating, you're going to treat for 1 cycle, 2 cycles, 3 cycles, and so on. And those predictions are better. So, so in that way, nuclear medicine colleagues, Jancy, so it is decoding personalized medicine. It is making it real, but it will only make it much faster, of course, if we employ AI in an ethical manner, from infectious diseases to, of course, cardiovascular, neurological, and of course, cancer, which is the bulk of the work into which I'll speak to now. So in neurology, I would like to really again remind us that we've got several disease-modifying drugs as we come to reach the ages of, say, 60, 65, and so on. Dementia can start to set in, and we've got various hallmarks of degenerative diseases and therefore biomarkers that we can label. And that's the beauty of it. So then with AI, we can say, what is it that we can try and target to try and give us a prediction of saying, yes, we can detect this very early, and then hopefully in the future also then maybe help those disease-modifying drugs to be converted by labeling them and, of course, treating. So this is no longer taking many years of trying to unravel before we can come to choosing what is the best approach that we can choose to have a scanner like this that shows you that this person is in trouble. You've got to start giving him some medication before it progresses further and go to death. And then this demonstrates that, in fact, we are speaking about it now, the 4AR, industrial revolution and so on. But in fact, nuclear medicine has started about this disease characterization a bit of a while ago. And then as it come to segment, how do you draw and then how do you come up until now? But of course, it had different names at different stages. And then now we're in a situation wherein we can have better predictions than before. And then, of course, better radiopharmaceuticals that's contributing. In terms of cardiovascular diseases, we know that in our country, of course, clearly we are having diabetes, hypertension, and then we are having atherosclerosis. Our vessels are narrowing, and then from time to time, there's fatal heart attacks, and that we can try and do the scans that will actually predict to say that if this person, if he's under stress, as you can see, the yellow is not, or the orange color is not seen there, he is having a problem. So we have to do either a bypass or give certain medication and change the lifestyle so that his cardiac muscles can go to normality. And then, of course, those kind of predictions can be easier, as you can see now with AI that clearly utilizing nuclear medicine techniques, but also radiology techniques. We can have obviously various way of how we segment, various way of how we choose the biomarkers and the blood results and clinical information, and combine it to give you an improved drug selection, and then select which type of trials, clinical trials we can embark on that would help us to prevent side effects and prognosticate, and of course have insight into pathology of having preventative diseases. So this is not theoretical, it's already happening and it's good, but I mean, it's a question of, again, as I have started at the beginning, by having collaborative and co-creation. It's very important, otherwise we remain with this AI skills that can help us, but that are confined, say, to echo only and not speaking to nuclear medicine, or MRI, not speaking to PET. And that's really where the problem is, or genomics in that way. So AI algorithms will only be powerful if you've got, of course, the commitment to working together and having multidisciplinary approach in what we do. In infection imaging, that still is a problem, things like tuberculosis in our country. But again, we can actually not only scan, but after scanning, we can, for instance, take numbers like this to say, what does the number of 10 mean? Does that mean this person is going to respond well to anti-tuberculosis in the predicted time of 4 or 6 months? Or is this person going to need 7 months or 11 months to be treated, so that we don't end up with problems of course, relapse, residual disease, and therefore people that are not healed, and therefore end up with XDR. So there are various ways that we have to do, and when we quantify the numbers, it shouldn't be just a number for the sake of it. It should be that it's going to help us, inform us going forward that indeed there's value in what we do. But that is only going to happen if there is big data, but there is harmonization of that, how we collect the data, and how do we standardize it. So now coming to the cancer part of it, the pharmaceutical industry, it's something we cannot ignore. We are fortunate to be working with various industries that are doing clinical trials that want to work with us at NuMeRI, and then that's how we want to, of course, see how we really have an impact in this, and then how does that AI impact us. So they will be coming, for instance, with certain drugs and molecules, sort of trying to go straight into the preclinical or rather the clinical. Then we can sit and look and say, but if you're going to label it with a certain isotope, it is likely to work, and it is not likely to work, and then come with a harmonious way so that we can have a labeled way, and then we can have a smarter way of doing phase 1 trial, phase 2 trial, and phase 4 trial data for humans. So in other words, then one is saying that in nuclear medicine, of course, just picking a lymphoma. So AI can help us show an image, to have images that are really not difficult to interpret, that are really informative, and that can also mean something to the patient. So it's about time when we do the imaging and then we speak, we engage with the patient as well. That can help us, of course, patients. When there's movement, we can correct that, and then AI can help to draw regions of interest around the lesions or cancer site, and then to predict the outcome, as I was saying, but to know how do we score you the response assessment. If this value has gone from 10 to 6, what does that mean? Does that mean it's a good one or not? And then and that way it's only going to happen, of course, if we really have a good way. And then, of course, the report has to mean same thing from one physician to the other. So, and then, of course, communication from referrals to everyone. And then when you have to come back, so AI has to remind us that it's about time you must go for your scan or for your blood, and so on. So otherwise, if you don't have that, sometimes you forget, and then something can crop up, or it can alert you to say, but at that time of scanning, when there was some auto-segmentation, something tells you that you actually have to go to radiology. They must go and assess something that we actually might not be seeing. So in other words, we must, as I said, harmonization, standardization of terminology is going to be important if we make AI meaningful. From nuclear physicians, as people are converging to prep us, from radiobiology, physics, radiology, as they come, we must speak the same language. And then in that way, then we can also start to simplify how we have a consultation. That is a usual problem. Many patients, usually when they go to the hospitals, they will have really 2 minutes to find somebody traveling 3 hours and only to see a medical doctor for 2 minutes, and that's set. And that can help because AI can help us to actually triage and help what is the problem, where and who must spend more time with the patient. And we have actually devised this, and this is going to be an important thing. And that information can be summarized and also be given to the referral places to utilize. That's how we can utilize, not replacing a medical doctor, but helping to make sure that in the long queues, how do we really get meaningful information? And then how do I speak to my other colleagues that must also intervene if it's not in my field? So having spoken about imaging in itself in nuclear medicine, how do we utilize this, and why is it important that we do this? When we scan, we want to scan fast so that we can scan many patients. But if you scan fast, as you can see, the images are not so nice. You cannot see well where you are, and you've got a lot of background. So, and this is when you scan the normal way, with normal time, as I said, then you'll do fewer patients and many patients won't be helped. So you can then end up utilizing the faster way of scanning, but using algorithms and models to then give you the same results like as if we have done the standard scanning, and therefore you can help many patients. So in terms of access and availability, so AI will help us in that way of utilizing resources that can actually make us do many patients. But similarly, we can give a smaller dose, even if we didn't scan fast. So with a dose that is supposed to go to one patient, we can scan 3 patients, but then make up that to be normal and still see the correct diagnosis using AI. So this just shows you how AI helps us as physicians, improving how to detect node by 16%, how to see the prostate by 26%. Otherwise, it's something that we could miss. And if we don't have AI-enhanced imaging or AI-helped translation. I mean, you can imagine going home without being told that we've got liver metastasis, which is very poor prognosis in about 14% of patients. It's a big number. So that is very relevant and helpful. And so we are saying that it helps us to individualize the oncology and the outcomes. And then, of course, those predictions are possible because then we can also know, for instance, as we have done in our place here, we can know that if an oncologist gives a certain drug, we can try and label it. As we can see, olaparib is one of the drugs that is commonly given for people that have got mutation, say BRCA mutation for breast cancers, but you cannot give BRCA that olaparib to all the patients because you might not know in vivo which patient has got that mutation. And then, of course, you cannot keep on biopsying as well. And then in some of the patients, it might be that some of the lesions in the primary cancer versus the distant metastasis, there is different expressions. So you need to be certain. So we can repurpose those and then label them and then just inject, and then you can have a way of looking inside in the patient that would be helpful. And that is even getting better. In the past, this kind of work it took us long, but now with AI, as you can see, we don't have, it helps us to not have a labor intensive. We can identify the target much easier and faster. And then, of course, usually you'd find that you've got molecules that are at least 100 or so. So to choose which one is a hit, optimal hit, and the lead molecule, it saves time and money. So then, and of course, then you can go faster into a phase 1 and 2, and then you can predict your pharmacokinetics and pharmacodynamics very well. And then you can redefine your blood biomarkers much better if you combine that with the AI rather than just looking at the manual, as I've shown you that. And then, of course, our diagnosis and prognosis will be much better than the conventional. So there is improved drug development with benefits to the patient, and therefore with less trial and error, with efficiency and much more going forward. And then, of course, as you can see, conventionally, only 10% of the drugs that you end up seeing, something like Panado that you see in your shelves there and that you go and buy, Sinucon, there might have been lots of drugs that had been there, and usually they would have failed and taken long. And that's why sometimes pharmaceutical companies end up with a very expensive price, because they would have spent a lot of money trying to see which one is the correct one. And only 10% of those will end up in clinical. You can imagine having evaluated 70 molecules, spending money and only end up with 7 that might end up there. So it's a lot of, so we can accelerate this identification. We can see which patients will benefit from certain drugs. And then, of course, the high throughput will be possible. And then that will be with efficient data that is there, provided it's efficient. And then, of course, in that way, we can do clinical trials much better. The study designs will be much better. The setup and the electronic case recording of the forms, so that if a patient later on in years, you want to see what was the information, it can be there and it's kept electronically, and then we can communicate with offsites, and then clearly we can obviously reanalyze that data and go back to it if it's stored electronically, and that data management is efficient with AI. And then, of course, in Theranostic in itself, tumor characterization is important, in the sense that cancer cells, if you start today by treating, it changes over time. And then as it changes over time, you need to be sure that you can have a way of predicting how it will change, so that you can monitor it better. And then as you do that, then you can try and have other drug that can help, because the initial drug might no longer help. And then, of course, you can also try and come with what amount, like initially you might have given, say, 20 millicuries. Now you are not going to be given 20, you need to give 70 or 80 and so on. So that has to be told by the predictions that will be coming, and that is happening. There's an example of some science chair. So an example of some of our patients, just to show that, predictions of selecting this patient with a prostate cancer with all the metastasis in the spine, almost all of the bones. We could predict that this patient will benefit if we give a certain dose. And then, of course, if we give over 4 cycles, and after 4 cycles, as you can see, the spine is clear, and then you can see there is no metastasis that is there. So that is good because and then of course you can measure that his kidneys has received a certain amount, because they are not, they obviously get the tracer as well as you treat, and then you can to predict whether they are not damaged or not. That's another thing that we do. So we do have novel specific biomarkers that we get patient stratification prognosis. Guess we can see in this patient again, we could see that we could select the patient, and we could see if this patient is going to have side effects or not. And then we knew that this patient will have side effects in the salivary gland at some stage. Although this patient, as you can see, having started with this, and then the patient is here and clearly clean, and that is over years that this patient was treated. So we know we can predict this, and this is AI derived, and then and that's very important and helpful, and this is very wonderful. And you can see again in this particular instance that we've got real-time analysis. A patient having been treated in 2018, by 2025, actually, even now, this patient still doesn't have disease. We know, for instance, at this stage, how much we could give, and then you can see in the lung, in the brain, the pelvis, that this patient remains clear, because obviously the changes that were there of the cancers, we could hopefully try and then predict them. So, but we have to do this within the ethical way, as previous speakers would have said, and then we have to make sure that there is benefit, safety, reliability, and then it must be collective, must be collaborative. And then we have to, obviously, with institutions such as NSTF, try and see that there is transparency to what we are saying, and then therefore propagating to institutions of government to say, how do we really take this in a legal manner that is to be used faster and better. And thanks, Chair, is my last slide again, to say that we have to make sure that we have to speak common terminology. We have to make sure that indeed we think out of the box when we are speaking about this concept of AI. Thank you.
There was one question, which is your work affected at all by the funding cuts by the United States to, for example, PEPFAR?
Okay. Thank you so kindly. Yes, to a smaller extent than the other colleagues that were more, for instance, in the infection space. We're doing infection, but to a limited scale. So therefore, our collaborators that were supposed to work with us and therefore pay for the isotopes will no longer be doing so. So us directly at the moment, not so much, because we had been working with more Europe than America. Anyway, for some reason, we work with EU more. So, for instance, EU, we've got a grant, 22 million per annum, that they help the people of South Africa so that we can have better isotopes and access to them. Yes.
That is good news. Thank you.
Yes.
Kwasi Gabuza asks, how applicable to other affordable scans like ultrasound?
Okay. Yes, ultrasound. So as one speaks about nuclear medicine, without really having clear patient pathway, it will really be speaking in vain. So you've got to start with all the non-invasive, more readily available modalities like ultrasound that will identify patient 1 to patient 2 who should be sent to nuclear medicine, who should be sent to cardiology. For instance, just 2 days ago, sitting analyzing a PhD grant of somebody that is going to use ultrasound, but in a remote area, not in a sophisticated area, that would help a GP, a nurse, a clinical associate to say this and this features means that, and therefore the patient will not be wasting time. So it is applicable, and I'm happy that, of course, it doesn't have to be nuclear medicine. It must be in all modalities. There are really means and ways of trying to come with a reliable interpretation and diagnostic ways. Ultrasound, X-ray, and again, things like chest X-ray. Sorry, I'm talking a lot. Chest X-ray, for instance, we've just done, I have a PhD student of mine that has just finished on trying to see when you have a chest X-ray and you are sitting remotely, what must you say to say this is TB and this is not pneumonia? And that's really simple things that I help, because if you miss it at that stage, the patient gets to be lost. Yes, it is applicable, really.
Thank you very much. Zama Moni asks, what would the prediction criteria be for progressing to clinical trials? And how do you ensure that AI is being accurate?
Yeah, I think thanks for that. But predictors are going to be basically clinical trials are different from different times. And usually low middle income countries tend not to do clinical trials. And clinical trials are important to bring those expensive drugs for free to our patients. So the more we do this and say that, let's say, for instance, in Belgium, they would have said the prediction is that if somebody has got a hemoglobin of 20, platelets of 30, then he must progress and so on. But you find that in South Africa, it's actually not the same situation. So those predictors of saying who must go to the clinical trial from routine might differ slightly. Hence, that's why we advocate that, yes, we must do that. At the initial stage, we'll take predictors that are really set out by other people. Those predictors will have been, say, the histology must say this, the blood must say this, and then, of course, the scan must say that you have more than 3 lesions first. But those things shouldn't be cast in stone, and we shouldn't stick to them. After having done fewer patients and fewer trials, we should set our own trials to give better predictors. We can say, for instance, in an African setup or with somebody that is of a certain socioeconomic status, you also have to include, for instance, the renal scan of, say, 30 and not 40, because if you include 40 for him, that patient will not cope well. So predictors are a moving goalpost depending on what we get on our side. And then, of course, we've got to sequence the therapies. The trial might say to you, start with drug A and not drug B. But if somebody's got a poor prognosis from the beginning, then you might have to start with drug B and not A, as say for instance in Germany. So it's not as easy as that the AI will help us based on European models. It will help us from the beginning, but we have to do our own ones. But we need big data. Hence, I've shown that map of Africa that, I mean, in South Africa, in the country, we've got to have our own human and normal data so that we can have better predictors. As I was showing the brain scan for dementia, it might be that as well, that for you've got to normalize to a normal brain, but the current we normalize to a brain that is derived from Europe, but that might be wrong. For instance, we might over or underdiagnose.
Right. Yes. No, we definitely need our own data, and you're participating in collecting that data, of course. So I think we're slowly making progress. Busi Aland says, thank you, Prof Sathekge, for your powerful presentation on nuclear medicine as a game changer. Given the precision of nuclear theranostics in targeting specific molecular pathways, is there scope to apply similar diagnostic frameworks to multi-component integrative formulations, particularly those derived from indigenous plants? Could nuclear imaging or tracer technologies be used to track compound synergy or bioactivity in vivo?
Yes. So, of course, indigenous medicine has not been given a fair chance, but probably because maybe there hasn't been objective way of analyzing it. Let's say, of course, there's indigenous medicine that's supposedly to do X and Y. I think one of the fairer trials, except just looking at the patient's outcome and clinical follow-up, it could be by in vivo imaging. I mean, we can have the pre and post medications that are given, so conventional medicine versus indigenous medicine, and compare objectively, not only on the clinical. That's how one way we could help, but we could then also ask in vivo in a laboratory to say what is contained in that indigenous medicine, and then we can see if there's anything that we can label, and then actually then do an imaging, not a generic imaging, but an imaging targeting what that indigenous medicine has. Say that indigenous medicine happened to have, I'm just giving an example, somatostatin or so, and then okay, but this is actually containing this. So if we image going with this type of receptor, that's how we can actually track it better. And or utilizing nuclear medicine later on, if we can see it, we can treat it to target with a radioisotope that can treat. So then your payload for treating can become a nuclear medicine isotope if that is feasible. So indigenous medicine has to be studied, but then of course, together with the other chemists. So there's computational way of actually trying to analyze what biomarker we can extract to target and help whatever the medical application that is given to us.
Okay, thank you. Last question. Thavrin Manikam says, thank you, Prof. Are you doing any or a planned future research in advancements or improvements in brachytherapy for prostate cancer? For example, in brachytherapy, there's a risk of radiation exposure to other tissue organs beside the prostate.
Yes, brachy, of course, inserting those isotope and then it irradiates. So brachy is starting to be used less and less, for instance, in prostate cancer, because of course, obviously the best, I suppose, with the robotics, which is, sorry, I didn't get to that, but robotics is another for the industrial way of doing medicine. And then robotics would actually be now targeting how to operate those, which is the first prize, if you can. But if it's not operable, then nuclear medicine isotopes will, if we image and when we can target it, we can then treat and then shrink it, and then we can still operate, or we can just use nuclear isotopes to try and target, but not in a form of brachyseeds, of course, just a simple IV injection, but then it won't go to other areas. If you have imaged and seen that it's going there, you can actually try and do that, but you can then assist phototherapy and to external radiation to actually target a certain area. If we have image, then we can really then be directed toward that specific small area, not looking at it morphologically, but looking at where it's active. So in a combination where we can advance, we are advancing and we are helping to make sure that there isn't benefit of irradiating the normal tissues. So yeah, there's various things we can actually do to have, and then there's ways that that's going to come that we can do intracavitary insertion of our nuclear medicine isotopes, like alpha therapies that travels a short distance. So they are stopped merely by a paper. So if you put them exactly in that specific area, especially say in the brain area more than the prostate, but the same will happen in the prostate, can also happen to be futuristic in that way. So to really say, not taking your time, don't say, I think nuclear medicine is going to be seriously a serious pillar of oncology going forward. As we speak of oncology, radiation and surgery, it's going to be one of those pillars that you cannot speak about oncology without speaking about nuclear medicine to avoid things like brachy.